Thanks for tuning in to an Academy of International Mobile Healthcare Integration webinar. Matt, would you please advance the slides?
I failed already.
This webinar is being recorded and will be available for on-demand playback on the AIMHI website tomorrow. The slide deck PDF, as well as the Q4 benchmarking report, were included in your reminder email and will be posted in the chat shortly. To ask questions, please use the Q&A function in Zoom, represented by the double dialog bubble button. The chat will be disabled for participants, except to chat me as the administrator for technical support. AIMHI Education Chair Matt Zavadsky, would you please share some information about AIMHI?
Thank you, Amanda, and I'm sorry about failing you right from the start, not knowing when to click the slide. But congratulations again on the double dialog bubble button. Still amazing. So AIMHI, many people may not know about it. It's the Academy of International Mobile Healthcare Integration. It is essentially an association of the public utility model systems and other high-performance EMS systems that share the traits that you see on the screen right now. So essentially, these are folks that do their own dispatching, do flexible production strategy, they do peak load staffing, they are responsible for the revenue cycle, all of the things that really go into doing a high performance EMS system. You can see here the members that are part of AIMHI currently. We want to give a special nod to Harris County ESD 11. They are our newest member. So congratulations to those folks who are going through the vetting process and being able to join AIMHI as the newest high-performance EMS system. We are very excited to bring you this webinar, but we're more excited about the people who are going to be part of it. We want to especially thank the Center for Public Safety Management and the International City County Managers Association, who are co-hosting this. In addition to sending invitations to their members, they are also going to be making a recording of this webinar available for all of the ICMA members. It's very valuable information. Let's ask each of the panelists to introduce themselves, give a little bit about their background, their agency that they're with, and just for fun, the book they are currently reading or the one that they have most currently read as you end your introduction. So JP, we'll start with you, sir.
All right, thanks, Matt. Good afternoon, everyone. My name is John Peterson. I go by JP. I'm the executive director at Mecklenburg EMS Agency in Charlotte, North Carolina, otherwise known as MEDIC. We are an agency that does about 170,000 responses per year, about 115 or so thousand transports. And we have about 630 employees. I've been with the agency now for a little over a year and a half. Prior to that, I was the chief operating officer at Sunstar Paramedics in Pinellas County, Florida, which is another similarly sized public utility type model style ambulance service, also an AIMHI member. Happy to be here today. Thank you, Matt.
Thanks, JP. Regina?
Yes, good afternoon. My name is Regina Gadet Crawford. Historically, my background, I was retired from the North Carolina Office of Emergency Medical Services. After 34 years in state government, I decided to take off the regulatory hat and join EMS Management and Consultants as their advocacy liaison, which gives me the opportunity to continue to advocate for EMS across the country. So I'm so excited to be here. Thank you.
And Regina, what kind of services does EMSMC provide the industry?
Revenue billing cycle management. That's what we do. We specialize in EMS services. We do have some hospitals, but we primarily focus on emergency medical services and revenue cycle billing.
And do it very well. So thank you for being here. You're an important part of the panel. Adam,
Thank you,
sir.
Good afternoon, Adam Hines. I have had the privilege of working for Remsa Health for 21 years. Started as an EMT, and I'm currently their Chief Operating Officer, so very, very committed and dedicated. Remsa Health's had the privilege of serving Washoe County since 1986 as the exclusive franchise transport provider. We have about just over maybe 600 plus employees, 80,000 responses, 55,000 transports. with 4 helicopters. Excited to be here. One of the questions you asked, Matt, was what books we are reading. And I know I was so ready. That was the question I was ready for.
We're going to go back to the other two.
Yeah, and so we have a core cabinet meeting, which is a lot of my division leaders. And one of the things, I'm a Studer fan, and so we just, we're doing the Busy Leaders Handbook. It's definitely digestible. It's easy, and every session that we meet every week, we talk about a chapter. The other one is Janway's Immunobiology. This one's a page turner, and so I would definitely recommend
Sure.
the other one.
That's what you read at night in case you're having trouble falling asleep, right, Adam?
That's right. That's right.
All right, JP, we got to go back to you. Book.
That's
Current,
no, I totally forgot about that. So I am literally just starting this book, but I think I'll get a kick out of the title. It's called The Road Less Stupid. So it's about avoiding the dumb mistakes that sabotage growth and business decisions. So it's by Keith Cunningham. It was recommended to me as a good read. So I'm literally just starting out on it and can report on it later.
All right. And Regina.
Yes, I am reading Finding Me by actress Viola Davis. It's very interesting. It's her bio, and it talks a little bit about direction as an actress and just finding herself. So it's a very interesting read.
Are you going to be one of the replacement actors during the SAG strike?
Negative.
I thought
I don't
maybe you
make
were
the cut.
boning up. Okay, good.
Okay.
All right. Well, thanks, everybody. My name is Matt. I'm with MedStar Mobile Healthcare. We're the public utility model in Fort Worth, 180,000 responses, about 550 employees, been here since 1986. And you heard that from the other two public utility model systems. We'll talk about that in a second. These are our systems that have been around for a long time. And also the education committee chair for AIMHI. And the book that I'm reading is Patricia Cornwell, Depraved Heart. It's her newest book. I've read every one of her books. My wife and I are both huge Patricia Cornwell fans. If you've never heard of her, do some quick Google search on her bio. It's fascinating, and her books are riveting. Much better page turner than the bio book that Adam's reading, I can imagine. So congratulations for that. So I feel bad because I'm the only one not reading like a self-help book or something, but sometimes you just need to have something completely different to maintain your sanity. So, okay, so we're going to kick this off. The Academy of International Mobile Healthcare Integration has published benchmark studies for years. This past year, I should say, as we were wrapping up, we did it a little bit differently. Normally, it was a huge biannual undertaking. I think the other folks would agree it took a lot of time, energy, and effort to get done. This time we broke it up into 4 quarterly reports with the focuses that you see there on the screen. And we're going to walk through some of the highlights from these high performance, high value EMS systems to sort of show what's achievable and, quite frankly, what's around for a long time. Because again, all of these systems have been in place for a very long period of time, so they've withstood that test of time. As Amanda mentioned in the beginning of the webinar, you received copies of these. If for some reason you didn't, they are available on our website. You can just go to aimhi.mobi, see what we did there. I can thank Rob Lawrence for that. He got us the URL literally when we were changing the name from what it was to the Academy of International Mobile Healthcare Integration. So that is available. You can also view a lot of the latest news about the EMS industry and have a lot of fun with that. So with that, let's dive right into the very first part of this. So Adam, first question is for you. So in part 1, the first quarter of this survey, there's some demographics about the geography, the population, the calls. Why is this information important to EMS agency leaders and city, county managers, ICMA members?
So great question, Matt. You know, one of the things that amazes me every time that we come together, because as a high performance, high value system, a lot of the times we work very closely with each other. And so that's what we see. But interestingly, when I have conversations outside of that group, a lot of the times they don't know that, number one, AIMHI exists, and really how expansive and the number of variety of agencies that are covered. And as you can see in this slide, we're talking about millions of individuals that are covered with thousands of square miles that AIMHI members, particularly those that participated in this benchmark study, that provide confidence. You know, in EMS, a lot of the times we believe that we are almost terminally unique, right? That my area experiences something that maybe your area doesn't. And this particular benchmark study is so valuable that represents kind of the who's who in the industry and allows for us as agencies to better understand what we're doing, whether we're doing really well, whether we're kind of in the middle, or whether we're leading the pack at some of these things. And so I think you're going to find this presentation to be extremely valuable and holistic, whatever your vantage point is, whether you're an AIMHI member, whether you're a jurisdictional governmental jurisdiction, whether you're just new to the webinar circuit and you're wanting to learn more about EMS. But like I said, this really is the who's who in our industry that can help us drive where we're going.
Yeah, and a huge experience. I mean, 1.5 million emergency ambulance calls in 2021, which is when we got that last stat. So a lot of experience under this belt. JP, so part of the first quarters was talking about changes in system design. As you see here, you know, changes in response modes, staffing. What does this sort of represent to the audience and to folks like the ICMA members?
Yeah, thanks, Matt. So I think kind of the overall or overarching point that this slide makes is that our high-performing, high-value agencies are very nimble. So as we learn from the data that we look at and that we are provided, we have the opportunity to make changes relatively quickly that can make significant positive impact to responses, but also, and more importantly, to clinical quality and clinical care. And if we kind of take a look at each of these and unpack them a little bit. So, you know, bullet one, 36% of these systems have transitioned from all ALS deployment to a tiered deployment. Our system is one of those that has done that. And what we've done is taken a look at the data. And one of the things we realize is that in our system in Charlotte, about 60 or so percent, maybe as high as 70% of the calls for 911 that we run are actually BLS, basic life support level calls. And so do we really need an all ALS service to be running those calls? And so we look at that and determine that in our case, we don't. At 64% of high performance, high value EMS systems do not use medical first response on calls. That might be maybe a shock or a surprise to some folks, but as we, over the course, particularly of the last year here in Charlotte, have worked alongside our fire department partners, we have learned that really the most important thing to our fire service is that the EMS calls that they are dispatched on and run are calls where they can truly make a difference, right? So if there are calls that we identify together as calls with the fire department isn't necessarily going to be able to make a difference, why would we take that unit out of service and put them on a call where they're not going to make a difference? Let's leave them available for a higher acuity or a fire or some other type of call. And so I think you see systems that are other high performance systems doing things like that to help create better availability for our first responders as well, and just make a system that makes a little bit better sense. And then another really kind of a hot topic, no pun intended here, is lights and sirens response. And so we often in this industry call those hot responses. Or cold responses, whether they have lights and sirens or no lights and sirens. And there has been a lot of research and a lot of data that have shown that when we use lights and sirens, it is probably the most dangerous thing that we do as an industry. And what we've also learned, and you can see from the numbers provided in this survey, 61% of emergency of our services here are responding 61% of the time lights and sirens. And then if you see the bullet point below that, only 9% of those patients after we arrive on scene and transport are actually having some kind of a life-threatening emergency. So there's a disparity there of the number of times we're responding emergency to calls for patients who only actually need it 9% of the time. And we believe, you know, here in Mecklenburg that that's a disproportionate number that we want to impact. And in fact, here locally, we were actually closer to 76% of the time responding lights and sirens, and we just as recently as April reduced that down to about 20% after about a year of analysis and data and looking at that, because we don't feel that we should be putting our patients or our people or our community at risk by responding to lights and sirens to calls where it's not necessarily a life-threatening emergency. I hope that makes sense, answers your questions here.
Yeah, absolutely makes total sense. And sometimes we marry these two concepts together. So our system, much like yours and a lot of the AIMHI member systems, went through that process of reprioritization, looking at those calls, looking at the data. And we, like you, we reduced on March 1st, we put a new reprioritization plan in place and dropped from 74% of our 911 calls getting a hot response to 34% of our 911 calls getting a hot response. And then when you look at the first responders, you really want them available to go to the high acuity calls, to the babies not breathing. I mean, let's face it, our country has been at 6, 7, 8% cardiac arrest survival for decades, and we have not moved the needle. And, you know, we don't want to have first response where it's really needed for chest compressions and those really important BLS skills. We want them available. We don't want them delayed 2, 3, 4, 5 minutes because the next station has to come over because the primary first responder in that area is on a twisted ankle call. So our fire chief here in Fort Worth made the very appropriate comment while we were going through this collaborative process to say, listen, if MedStar is not going hot to the call, we probably don't need to go. So that should be our response plan, is that if the call's not serious enough to get a hot ambulance response, it probably doesn't need first responders. So that's what we did. And it made it a very synergistic collaboration. So, but JP, one of the hottest things that, I don't mean to use hot again, one of the most controversial things that have been discussed over the last several years is this concept of response times. And as communities evaluate costs and costs of system delivery has skyrocketed, as many organizations know, and certainly as ICMA members and EMS agency leaders know, when we surveyed as part of the benchmarking study these highly performing EMS systems, take note that for the low acuity calls, there were people on this list who said, hey, their response time standard for a low acuity 911 call is 26 minutes, 30 minutes. And I want to specifically ask you to talk about yours, because at the time of this benchmarking report, you guys were at 60 minutes. And some people on this webinar would say, 60 minutes, that's heresy. They're killing people. Talk to us about that transition in your system and maybe what's currently going on there.
Yes, thanks, Matt. So 60 minutes sounds like a long time. So let's unpack that a little bit. I think going back to a little bit about what we were talking about before with responding lights and sirens, I think one of the things that we realized in this industry is that responding lights and sirens every time someone calls 911 in 10 minutes or less is not only, it's not the right thing to do, it's not sustainable. And over the last 5 to 10 years in particular, one of the things we've seen in our system that I think many other EMS systems across the country have seen is a significant rise in what we call low acuity calls. These are patients who call 911, but they don't necessarily have a life-threatening medical emergency. In fact, in some cases, they may not even have a medical emergency at all. They literally just need help navigating the healthcare system. One of the things I think we understand as EMS is that we are sort of the backstop, if you will, of the healthcare system. When people run out of options and they don't know who else to call, they call 911. It could be for something as simple as help filling medications. And so we've got to triage through these calls and utilizing a medical priority dispatch triage process where each of our dispatchers are trained and certified emergency medical dispatchers, which in the state of North Carolina is a medical certification. We utilize our triage process to identify those calls that are not high priority, life-threatening calls. And for a period of time back, starting in January of 2021, we decided to utilize a 60 minutes response window for that. Part of that, was in full transparency due to, at that time, the impact of Omicron on our agency. We had, I think, 40 or 50 employees out sick. We were having staffing shortages, and we were having this high influx of low acuity calls. How do we better mitigate that? so that we can make sure we prioritize our sickest patients and make sure that we have ambulances available when they're needed for those sickest patients who are truly having a life-threatening emergency. And so we decided to go slower on these low acuity calls. And after a course of about a year, we ran about 30,000 of these calls in the 60-minute window. We actually, even though we say we have a response goal of 60 minutes, our average response times was actually around 32 minutes. So for the most part, we had the ability to go considerably faster than 60 minutes, but we learned a couple of valuable things from this. One thing is that over the course of that year, we really only had about 3 official written complaints about response times out of 30,000. And the other piece of that is that we found out that this was absolutely safe for us to do. So, and that our dispatch priorities and the protocols that we're using were accurate. In fact, 99.3 to be exact % of the time, our dispatch was accurate and the patient was indeed a low acuity patient. Less than 1% of the time, only about 0.7% of the time, did we ever arrive on scene and find a patient actually having a true life-threatening medical emergency. So we feel it was very safe to do that. We have since expanded this and done a complete overhaul of our response configuration here at Medic. You can find that on our website, medic911.com, if you'd like to learn more information about that. But we now have a step system of our highest priority calls, and then a 15-minute, a 30-minute, 60-minute, and a 90-minute response tier now as of April 17th of this year. So that's where we're at now.
90 minutes. And JP, are you stacking bodies like cordwood at County Hall or?
No, sir. And I said 90 minutes, and some people, whoa, they went even longer. And let me tell you a little bit about the 90-minute, just real quick, if I can. That's a very, very low percentage of calls. It's like 0.1% of these calls end up in a 90-minute response. And to get in a 90-minute response window here, you have to have already been had an initial triage by an emergency medical dispatcher, follow-up triage by a nurse. We transfer them to our nurse triage line. The nurse has determined that the patient doesn't need an ambulance, but the patient requests an ambulance anyway. We actually have a system here where once that person has gone through the nurse triage line, we'll offer them a ride share. And they don't need an ambulance. It's been triaged by a nurse that they can safely go by other means. Some people don't want the ride share. We cover the cost of the ride share, but some people just refuse that and want an ambulance. Those are the people that get 90 minutes, just to be clear.
Okay, makes perfect sense. Thank you for that clarification. All right, Adam, back to you. We're going to put you a little bit on the hot seat. Accreditation. So you'll notice here that, every one of the AIMHI members have at least one accreditation, and most have 2. And I think maybe REMSA might have more than that. But why is accreditation important, and what does it let you do?
Well, I may be a little bit biased. So for disclosure purposes, at one point, I had the privilege of sitting on the International Academy of Emergency Dispatch, working with the great Kim Rigdon and on the board of accreditation. So I'm obviously very committed to accreditation. Particularly in dispatch, we have multiple accreditations. We were the first in the world, I always like to say that, to not only be EMD accredited Center of Excellence, but also ECNS, so Emergency Care Nursing System. And we currently are awaiting review for EFD as well, because we are able to provide EFD for a fire jurisdiction. And so our organization, and it may have been rooted in when we went to negotiate our contract and in the franchise, we had to set some performance standards. It's very easy for somebody to say, I'm the best, and this is what our standards of cover are, this is what we're going to do. But when you have a third-party agency, many of these in EMS in our industry using best practices, benchmarking similar agencies to each other, sometimes using evidence-based basis to provide a standard that lets your community know you are committed. Day one during new employee orientation, we like to share and tout our accreditation, but let people know that, you know, you came to an organization here at Remsa Health and many of our AIMHI members that are committed to quality, committed to ensuring a certain standard. And with that, it becomes the standard of care in your community. And so there's times where you may have conversations with individuals in which they're like, that doesn't make, it doesn't matter. We don't need that, or that's not as valuable as X. A lot of the times those may be underperforming agencies. And if they aren't, they may just not necessarily understand, particularly with the AID. When you go for ACE accreditation, you talk about the 20 points of accreditation. Well, if you know 20 points of accreditation, it's really like 150 points of accreditation because of that subgranulation. But let's think about this in terms of a business, and how does accreditation help us as high performance, high value EMS systems do different things? And one of those is in our education department. We're currently working with the great University of Nevada to progress the profession and confer an undergraduate degree in the School of Public Health that allows for our individuals to get credit and for us to be able to offer the option for financial aid or scholarship opportunities that wouldn't be necessarily provided or available to our team. Being KHEP accredited allows for us to pave the way that says we already have some of these standards that are needed in the university system that allows for us to progress that relationship. In addition, in order for us, and all of us on here know that sending an ambulance, lights and sirens with a fire truck and a police car and a bulldozer and a helicopter to somebody that has a low acuity complaint is not in anybody's interest. And when you are accredited, it allows for you to work with a nurse health line, an accredited nurse health line, as we do here at REMSA, to begin to make an impact into those low acuity complaints. As JP said, it's not that these individuals, these people in our community don't need care, it's just they don't need an emergency ambulance. And so how can we take a piece of the pie and safely navigate individuals to the right level of care? And accreditations open the door. Finally, I'm going to say something about our medical directors. We have great medical directors at Remsa Health. There are a lot of industry renowned EMS physicians in our practice. Having the confidence, you know, many of them may not be EMS fellows, some of them may not necessarily 100% understand our industry, but having the confidence and the credibility and the standardization and that best practice infrastructure allows for us to progress our care. That's why it's important to have accreditations.
Yeah, you know, as I think about it, the way you described it is excellent. And again, many of the AIMHI members and many communities should have dispatch accreditation through IAD or ACE, ambulance operations accreditation through CAS, or through CAIMS, the other accrediting body that does ground and air. But it's not much different than an ISO rating. So the fire service strives to have an ISO 1 rating. That's an external review. That's a level of service performance that they put on the side of their fire trucks. We're an ISO 1 community, and having CAS accreditation, CAIMS accreditation, IAD, ACE accreditation, those are big deals, and they're significant financial investments. But you can rest assured that when a certified emergency medical dispatcher in an ACE accredited dispatch center has determined, following the protocol and the training, that a high acuity call is a high acuity call, a low acuity call is a low acuity call. It really serves as sort of the foundation to know that you're going to make good decisions about resource allocation and ALS, BLS, response time designations, et cetera. So it is a big deal, no different than perhaps attaining a ISO rating.
One last thing that I will add to that, Matt, I think that you bring up is risk. I think all of us are in a business where there are times where we have to have uncomfortable conversations, or our organizations put in uncomfortable conversations relative to risk or liability. In addition, I've had the opportunity to sit and work as expert witnesses, and you definitely can check some boxes, not necessarily that that's the intention, but you can check the boxes and provide some at least standards of relief when you have accreditations, when they're going through and they're having, well, why is this policy what it is? Where does that come from? Who made that policy? Why is this important? It really is kind of a backstop that reduces some of that liability and risk when you're in those situations. So thank you.
No, absolutely right. And you can probably point in REMSA Health's policy manual, a couple of them that are the AIMHI policy, because you did something that you probably shouldn't have, and we better make a
Definitely.
policy about that. So,
Definitely.
let's stay with this concept for a second about PSAPs and accreditation. So there's huge discussions and a lot of them going on across the country regarding PSAP, public safety answering point consolidation, and efforts to reduce staffing shortages, reduce expenses, enhance efficiencies by consolidating 911 centers. As you consider that in different communities, when an organization has accreditations like this, what are some of the considerations that communities really need to take into account when they talk about merging or consolidating PSAPs?
So this is actually so appropriate for us, and our organization, our region, is very fortunate to have very close relations with the jurisdictional partners, and I believe we work very well to try and provide care in our community. We recently had a conversation about consolidation, and when you say that word, a lot of the times there are going to be people that aren't going to show up to the table, depending upon what agency and what area you're from. But I'm very thankful that we actually were forced, and so our jurisdictions and REMSA Health got together and we said, we have got to do better for our community, and how can we do it? And so that conversation was forced. It was facilitated by an outside facilitator. And the interesting thing, when you distill it down, I think everybody wants to do the same thing. Everybody from every vantage point, whether you be the primary PSAP, the secondary PSAP, whether you're doing EFD, EPD, EFD, all of those individuals are working with the intent to do what is best for their constituent, their citizen, their patient, the caller. But how is it that we can change it? And so the facilitator really went and poured a foundational kind of our guiding principles, which is, let's look at this from the caller's perspective. What is best for the caller? And you can have different sides of the argument. Is it providing care at the first point of contact and never transferring the person? Is it transferring the person to somebody that is skilled and has experience in being able to provide whatever they need? Or is it a combination of both? In addition, the word consolidation potentially provides people with, I'm going to be absorbed, or we're going to have to work under the same umbrella. And I think we all could probably point to systems that are single systems, right? Single point systems where you call one person and they handle it all and everybody's under one roof, and they don't work well. You can also point to systems that are disparate, but working under a common principle with common systems and common conversations that help drive performance. And you can say that really works specifically for that community. And so I think what is important here is if you're not frequently having conversations with those individuals that may be co-response partners, maybe PSAPs, you need to. You do need to understand where there's overlap and what you can do and how contingencies play. And I think for us, we're not done. This is a conversation in which we'll continue to evolve as new things come available. Particularly in our region, we're looking at a common CAD. There were disparate CAD systems. And I think one of the opening statements was, do you look at the expense of what a potential consolidation is, and is there an ROI? In our particular case, there is obviously a significant upfront cost to some of these efforts. However, we see system efficiency that is gained, and we see a decrease in some of that expense over time that's shared amongst the jurisdictions, with us supporting the guiding principle that it is going to be fluid. It is going to be patient-centric. It is going to get the patient to the right place with information being shared fluidly so that we don't put our responders at risk. Those things, I think, are kind of the basis and what I would recommend places take as a practice.
Excellent. Thanks, Adam. Regina, you're not off the hook.
Yes.
Interesting question for you. So there's this debate that goes on, certainly in high performance systems and others, about tiered versus single ALS deployment. Jonathan Washko, one of my best friends, brother, and I have this conversation all the time about there's a revenue hit if you start using BLS crews in the field, like you heard JP and others are doing. What's been your experience from a billing perspective when a system transitions from an all ALS to a tiered deployment system?
Matt, obviously, there's going to be some reduction from an ALS call to a BLS call, but it actually has been proven that running a BLS service is best. That we do the billing for, providing more transports, BLS transports, due to the staffing shortages that we've all seen and the changes in the service delivery. But we have not seen a reduction in revenue. It actually is proven to be more efficient to do the BLS runs. I mean, it makes more sense than the dual staffing. So we've not seen a large reduction in that.
Yeah, we did a quick analysis with the help of EMSMC looking at only about 50% of the calls that we were doing when we were all ALS were getting reimbursed at the ALS level. Because even if you have a paramedic on the call, doesn't mean that you're going to get reimbursed at the paramedic level. And CMS's past practice of, hey, if you're mandated to send ALS, we're going to reimburse you ALS no matter what. That went away like a decade ago. Has that been sort of your experience as well?
It has, and actually deploying paramedics in QRVs can provide ALS assessments, which is a better use of that. And you can still be able to bill for those transports, where if you send 2 paramedics, it's not frequent right now. I mean, I really think it makes more sense than what we've seen across the board. And we're dealing with several agencies, hospital, governmental, private providers. So across the board, that's not the case. I mean, sending the BLS unit makes more sense. Changing your staffing patterns has proven to be more effective than continuing to do the dual paramedics on the unit.
Sure, absolutely. And it's interesting as we look at this slide from the clinical outcomes and TQM part of the benchmarking study. If you look at Richmond Ambulance Authority in Virginia, note that their minimum staffing for a BLS unit is I hate to say it, a driver who is CPR certified and has had some special driver training, but that's not that unusual anymore. There are states, because of the pandemic, because of staffing challenges, that have authorized. Maine, Wyoming, a number of states have authorized minimum staffing of a non-certified and a certified person. And we are part of a coalition that is actually studying patient outcomes based on crew level of staffing. EMT, driver EMT, driver paramedic, to look at patient care data and dispatch data to say, and in some cases, hospital data, did the patient that got treated with a crew that consisted of, like in Richmond, a CPR certified driver and an EMT have a better or worse outcome than someone who had 2 paramedics on that ambulance? And therefore, what are some recommended best practices and maybe recommended staffing configurations based on emergency medical dispatch determinant that it is absolutely safe to send a driver and an EMT to a 26 Alpha 1, because 0.2% of the time they get ALS care, whatever. But so we're working on that. And I think this is something that, again, our profession needs to sort of get over ourselves, and that we really need to start going back to what seems to really make sense. All right, JP, back to you for a minute. Part 3 of the quarter 3 of the report, when it came out, talked about medical direction, fleet, et cetera. When we look at the 100% of the AIMHI members doing patient experience surveys, and in most cases using an outside agency to do patient experience surveys, why is that significant?
Well, one, it shows that these agencies take very seriously the level of service that they're providing and wanting to get feedback from their patients and the communities they serve. But if you think about it, we're getting in 2023, just about anywhere you go or any service that's provided to you, there's a survey at some point, whether it comes to you via email or something like that. And you think about, why do these companies or agencies, why are they doing this? And the important thing is to get feedback on the level of service, right? Was our problem with our level of equipment? Was our level of service right? Was our response time good? How did our people treat you? Did we do a good job? Is there something we can learn from this? Is there additional training that we might decide we need to provide to our staff based on information we get from our patient surveys? And really, it's just a good pulse check, a good, a pulse check of how we're doing in our community. And I think it's super important to utilize a third-party service for a couple of reasons. And I think the reason why, speaking for my agency, and the reason why others probably do this is credibility, right? You want to make sure that it's not just me, JP is the executive director of Medic, that says, yeah, the patients in Mecklenburg County love Medic. Everybody loves us. We have actual data from a third-party source who is doing phone calls, or whether it's a letter in the mail or phone call, or however it's done in the different system that you operate, how you prefer to do that. You're getting real feedback through a third party. And then transparency. I think you have to be transparent with that data, and you've got a credible third-party source and transparent data, and it helps to provide trust and build relationships with your community as well. So it's a lot of different important stuff there.
And is it also true? God, that sounded like such an attorney. Do you also think that hospitals, physician groups, other folks that are held to performance standards by payers like Medicare have to do it the same way? Have to use an outside agency, it has to be publicly reported. So if we want to truly admit that we are healthcare, then we should do these surveys like the rest of healthcare does.
Absolutely. Yeah, and if you're not, you really should strongly consider it.
Yep. Adam, I want to come back to you for a second. The last two bullets on this particular part of the study shows that applicants are down, turnover is up, but pay is up. I know in our organization, we increased wages during the pandemic almost 58% in the 18 months surrounding the pandemic. Why is this significant to our profession? Why do you think we're seeing a decrease in applicants despite pretty significant wage increases? I think you're still on mute, Adam.
Similar experience here at Remsa Health. We've had individuals that have left our organization and are going to receive less money. I think, obviously when the pandemic occurred, we saw many people leave healthcare. We also saw a decrease in the number of individuals that were being trained at institutions as a result of some of those restrictions. And it's a different generation of workforce. And so, what is necessary is that we look at the things in which are most important. And particularly in this generation, we know that employee engagement is important. So considering tools in which allow for us to communicate. We just recently rolled out a mobile communications platform that is similar to a Facebook type feel, where you can like and chat and share, and that has been very successful. In addition, we're doubling down on the things in which we know our providers struggle, our clinicians struggle with, which is their mental wellness. And so we increased 80% of the funds in which we previously had budgeted to look at an embedded mental health provider that people can become comfortable with and understands the environment in which we provide care. We want to make sure that those that are more traditional and want to access care through a traditional EAP program, they have access to it. We bolstered our peer support from 2 people up to 35 with the anticipation of going to 65 so that it's diverse and is representative of our organization. In addition, time off is important. Looking at different shift schedules. We recently went to 10-hour shifts so that we can improve the work-life balance. Those just shaving, previously we did 12-hour shifts, so we did a 48 each week. Just shaving 2 hours makes such a difference for individuals that want to get home for their children's soccer game or to get dinner. A 12-hour shift with a late call turns into 14 with a drive and decompression, which is 16. And so I think pay is important, and we need to continue to push to improve the amount of money that we're paying these talented team members. but we also need to look at the things that are making a difference in their lives.
And Regina, did you want to add a comment to that?
Yes, I did, Matt. I wanted to go back and talk about the 91% use of external surveys and then touch a little bit on what Adam was talking about. Out of 287 providers that we do billing for, about 75% of those do external surveys. And in North Carolina, we are currently getting ready to launch an EMS survey to look at the state of of EMS in North Carolina in order to drive funding and get support for our agencies across the board. That's a huge piece. We've got to have data to provide back, and I think these external surveys are huge to that. That's one of our questions. And then to talk about a little bit of, as Adam mentioned, about the turnover, life balance. That's huge. That is exceptionally huge across the board. We've had roundtable discussions, and the number one priority, it's not so much pay, is life balance. I want to be able to be off, spend time with my family. So I think all those things are going to drive where we go in EMS in the future and how that affects recruitment and retention as well.
Very true. Great comment. Adam, let's keep the focus on you for a second. Peer-reviewed studies. So 91% of AIMHI members responding to the survey participated in IRB-approved clinical research. What does that say to you, and what should it say to local community leaders?
I think it just shows our commitment to an evidence-based practice. Gone are the days where you call and we haul. This is really moving, and we are migrating as an industry. National Association of EMS Physicians is pushing this. National Registry is pushing this, is to really work to professionalize and ensure that what we're doing is supported by the science, and we're being included in that science. And I know my colleague JP really leads the charge in many of those studies.
Yeah, JP, you guys and Medic have been in several very highly referenced studies. Is that just core to what your mission is like?
Well, it is, because we want to help drive the industry forward. And this is how you do that, right? Evidence-based practice, just like he's talking about, and learning and finding new innovative ways to provide quality healthcare to people. And then take it kind of the next step of what you learn and what you glean from these things is how you then incorporate that into training and results. And I think one of the things we've seen in the AIMHI surveys here is that the members of AIMHI are very committed to providing training through their medical direction to keep people up to speed and to make sure that the newest, latest, greatest, if you will, is in those communities.
Yeah, I mean, look at the back of the napkin math. I mean, if the average investment in medical direction and training in QA for these member agencies is $1,100 per team member, just anybody who's on the webinar watching the recording, do the math. I mean, if you've got 2,800 providers, if you've got 100 providers, that's a significant investment, and it just represents that commitment to clinical excellence. So that's awesome. I want to look at the last bullet point here, or the last two really, and maybe Adam, back to you for a quick comment. The acquisition costs for ambulances and just costs of supplies and equipment and capital in general. What have you guys seen, and how does that impact your cost of service delivery and funding?
Well, I will have to say that we had to diversify. For many of you that may have a known history of Remsa Health, for a long time we had a president and CEO, very magnanimous, and he was committed to drinking Diet Coke, flying American Airlines, and only staying at Marriott's. And that worked for a long time. However, we've had to change. And so our fleet, particularly our fleet, and the comfort of our crews was obviously top of mind. And so we always had Type 3 ambulances that were provided by a single vendor, and they looked exactly the same. But for sustainability and to ensure that we are providing what we need to our organization and to our community and to our team members, we had to look for different options. And so we have diversified our fleet, which really created a challenge amongst our organization, because our mechanics were our fleet team was very familiar with a certain body type. We had to exclude certain body types because the infrastructure to potentially look at type 1s was going to be different than type 2s. And so all of that has been at top of mind for the last couple of years. I think we're now in a position where we have better leverage and conversations with our vendors because we are able to diversify and we're not necessarily committed to certain things. That has opened up opportunities that really put us on a path, a more sustainable path.
Matt, I cannot hear you.
Oh, that's because I was off mute, put it on mute, when I started to talk. So thank you for that. We're going to switch to the part 4 of the survey, the quarter 4, which is the financial and productivity metrics. When you look at this kind of data, and again, total responses, almost 1 million responses just in that quarterly report that we just sent out on Monday. JP, what does this type of data say to you about the productivity level, the efficiencies for these high performance EMS systems? Is this really what high performance is all about?
Yeah, actually, Matt, it is. And if you were to look at these numbers and you're not familiar with, say, what is unit hour utilization or some of these other numbers on here, this slide might not make a whole lot of sense to you. So I'm just going to take a real quick moment and just explain some of what I think are the highlights of the numbers that we're looking at here, and starting with unit hour utilization for response. When we talk about a unit hour utilization, just a very sort of broad, not technical overview of what that means is this is the percentage of time during the course of a shift where an ambulance crew is on a response. So they're responding to a call, on scene of a call, all of that combined in there. And as you can see with our AIMHI membership, the average is about 60%. We'll just round up and say about 60% or so of the time that a call or a crew is in service, they are on a response. And then the next line down, same sort of philosophy, but specific with transports. So the unit hour utilization for transports is that percentage of period of time that the ambulance crew is actively on a transport. And it's about 41% of the time on average in the case for the respondents to this particular survey. And so what does that mean? So we utilize these metrics to help us determine workload and efficiencies in our EMS systems. So we can look at these and determine that a 0.59 or 60% response utilization is relatively busy. And what that means is crews are running a lot of calls, it means they're getting a lot of experience, but it also means we're utilizing that ambulance well. It's not just sitting, waiting for calls and not running any calls. It's actually being efficient, running calls and utilizing those, but also knowing that level, depending on your system, is how busy you're running your crews, because you don't want it to be too high of a utilization, because then you start to worry about things like burnout with your crews. So it's a very important metric that I think just about every EMS system and ambulance service in the country uses as a measure to help look at the efficiency and the workload for the crews. And then as you kind of go down this, if we just drop to the bottom and look at the ambulance unit hours per capita, it's an interesting measure that you could actually use to give yourself some sort of rough napkin math, if you will, on just how, what do I need in my service, right? How do I know if I'm trying to figure out how many ambulances I might need or how many unit hours I need? You could utilize this number to help give you a rough idea. And you could essentially take this number times the number of people that you're serving. So let's say you have a city of 70,000 folks, and you take 70,000 times the 0.2555 there, you're going to come up with somewhere around 17,900 unit hours. Gives you a rough estimate, right? At least it gives you a place to start. And then you can drill that down too and divide that by the number of hours in a year, and you end up looking at something like 2 ambulances 24 hours a day. And that's really, again, rough napkin math. There's more that goes into it. Each community is a little different. And remember that one of the things that was said earlier on this call is that our high performance EMS systems utilize a dynamic deployment model, and we are prioritizing times of the day as far as how many ambulances we have, right? So it might fluctuate. So while the number I just gave you, 2 for 24 hours, you might actually need 3 ambulances on from 5 to 10 p.m. Monday through Friday, but you only need 1 on after midnight, right? And that helps you fluctuate and get to an average of 2. But at least there's a general idea that you can get from some quick math by looking at that.
Yeah, very valuable. And, I know we get phone calls all the time from city managers from across the country that says, hey, how many ambulances do I really need? And, what's an average productivity? So this is great information. So thanks for that additional clarification there. All right, Regina, not leaving you untapped here because your wealth of knowledge. So part of the Q4 report was the expense per unit hour, but really the revenue. So again, 1 million calls, 700,000 transports. These are busy systems. So they are running very well. The average transport fee from across that, member swath, coast to coast, north to south, $1,500, average revenue, $435, expense per transport. What do some of these numbers tell you? And what is the importance of knowing this type of data for the operation of your system?
Bill market rates, get insurance information, all those things are critical. We've been talking about costs and efficiencies, but at the end of the day, balancing delivery cost with the revenue maximization is critical and very crucial. Most the AIMHI systems run very efficiently with a lower cost per call per transport. The average expense per transport is about 603, as you mentioned, Matt. Both fire-based and non-fire-based. So, what it tells me is that communities can choose to keep the rates at the market or increase their public tax funding. Even with the best practices are used, at the end of the day, it's just hard to get the actual cost you need. And I don't have a recommendation for that, but again, you're not going to collect everything unless we get the actual cost. So again, we've got to learn how to calculate the cost and the unit hour utilization. I don't think we have any other options for that. It essentially means an ambulance call is on duty any time of day.
Yeah, it's funny. The cost of service delivery is dependent on, in some cases, your model, but your service request. So if you want gold-plated performance, it's going to cost what a gold-plated performance costs. If you can't generate that from fee-for-service revenue, and these are systems that have, I would argue, a pretty laser focus on revenue and clinical and all that kind of stuff, but low-cost providers, high quality, and revenue maximization is really the hallmark of a high-performance EMS system. And even under those best of circumstances, the average collection is $435, $436, but the cost is $603. The delta there is got to be covered by somebody. So that's why we're seeing across the country, systems are either redesigning, changing staffing levels, changing response time expectations to balance the cost with the revenue and reduce the reliance on perhaps public subsidy. But it's something we really need to look at. And Regina, you are blessed to be on the HHS Ground Ambulance Patient Billing Advisory Committee. I think GAPBAC is
That's correct.
The acronym. And this was information that was shared with them. And the EMT did a great job partnering with the Public Consulting Group. PCG does a lot of the cost reports for public agencies who get reimbursed through Medicaid, a supplemental payment. And when you look at the average cost of putting an ambulance in front of an address in 2021 across the board was $2,300 to $2,700, but Medicare and others are paying $400, $500. This is where you start to have difficult conversations in the community. And if you want a certain service level, you got to fund it. And it's not going to come from fee for service anymore because the costs have skyrocketed and the revenue hasn't changed. So the realistic expectation really needs to rule the day. And we're having conversations like this in our community here. And we've said a couple of times, you know, the balance between public subsidy, service level is really the intersection of what your wallet can bear and your stomach can withstand. You start making some of those balance discussions. So it is really important. All right, we're coming up on the top of the hour. I want to leave a little bit of time for questions. I know we're scheduled to go until the bottom of the hour, but just a couple of more things, Regina. The key metrics here: 6 of the 10 AIMHI agencies receive a local tax subsidy. The average subsidy is $8.28 per capita. But the payer mix of Medicare and Medicaid, why does this become problematic for agencies when they look at things like perhaps fee schedule changes in their local community? Oh, we'll just raise the rates a little bit and cover that deficit. What's the reality here?
The reality, Matt, and others listening on the call is that, you know, the tax revenue, the fee for service, it's a combination of the two. The payer mix, when an ambulance fees are billed, you're not going to collect. That collection rate is affected by that payer mix, and you're not going to get that with Medicaid being antiquated and Medicare barely keeping up with the cost. It's tough to get that. So you have to look at alternative measures. I mean, if you look at, and you mentioned it earlier, Matt, Medicare is going to pay 80% of the allowable. In that case, the best is $400. Medicaid has a set rate, which is antiquated, and it's not keeping up. In the best case there, you're going to get $300. So, you know, you're looking at your private pay patients, and those who lack insurance have insurance and have not met the deductible or co-insurance. So it's huge. Just some of the very things we're talking about in the GAPB. How do we address this issue? There are a growing number of patients that, especially since the advent of the federal marketplace, the high deductibles, it's just huge. I don't know how we fix that, but you've got to look at other metrics because it's just not. We have to look at other sustainable ways to cover the cost because our federal government directives aren't reaching that goal. So
Yeah,
that's
you're
what I
absolutely
see.
right. There are some communities who artificially underbill because they believe that will prevent patients from complaining about a high ambulance bill. The reality is that very few patients actually pay the ambulance bill. Those that don't have insurance, I think all would agree, just don't pay. They don't care what it costs, they're not going to pay. Medicare and Medicaid patients, yeah, they just, the Medicare and Medicaid pay a fixed amount, the commercial insurers. So we get into the whole surprise payment discussion. But you'll notice here that, you know, a lot of the AIMHI agencies are, you know, billing a pretty significant chunk of change to try and maximize that revenue. So don't be shy when it comes to doing the billing, because the collection rates are, as you see here, very difficult. And you'll notice that only about 1.7% of the revenue received by these AIMHI agencies come from patients, because patients just don't pay. We have to provide service, they don't have to pay. But when you look at, you know, Medicare and Medicaid being close to that, you know, 30-40% of the payer mix, and commercial insurance is only 30% of the revenue that we collect. This is where the public subsidy really comes into play if the community wants a level of service that fee-for-service billing won't support. Then you've got those tough decisions to make. And, you know, we'll just comment on this, Regina, for you, is that really what this shows in the last quarter's report is that overall, the cost of service delivery is higher than we're getting reimbursed by Medicare and Medicaid. That's why there's a lot of efforts going on in states across the country to increase the Medicaid rate, working with Medicare to be more realistic about what Medicare allowables are through cost reporting. So if your agency, by the way, for the EMS professionals and leaders that are on this webinar, if you're due to do cost reporting, please do the cost report, make sure it's accurate, because the data from these cost reports will hopefully show Medicare that, yeah, we've sort of been way underpaying and we need to adjust the fee schedule and pay what it's costing to deliver this service. So it's going to be really important. So
it's huge, man. I agree.
Okay, so we've got, it's little after the top of the hour. Amanda, I want to turn the floor over to you to see if anyone wants to raise their hand, if they've already texted in Q&A into the box. What can you tell us?
So we have 5 questions, and I think that in the Q&A, I think that will grow. Dr. Kramer wanted to know, why would one of these agencies not be accredited by CAS or IAED? I think that they all are.
I was gonna say that might be hard for most of us to answer because we all are accredited. I don't know. Adam, you come from an accreditation background and you've gone through several of them, both on the air and the ground and the education side. What are your thoughts for Dr. Kramer?
I think there was a comment that I will give credit to that probably will say most of what I will say, which is it's time and money, and maybe an understanding of the value. You know, early in my career, I had somebody that was a leader of mine that says there's no value in having a degree in EMS. I don't have a degree in EMS, but having a degree in general. And so I think that was misguided. And so there may be a misunderstanding of the value of some of these things from the vantage point. They can be expensive, and not necessarily the cost of the accreditation. That may be only a few $1,000s, but the infrastructure to ensure that you support it. And I will tell you, there was an accreditation at one point that we had on ground, that we have on air, that we decided was just not appropriate for ground based on some of the requirements that were more air specific. And so we decided purposefully and thoughtfully that just was not going to be something that we would continue. And so I would assume that organizations are in similar positions when they're looking to whether or not they want to have an accreditation.
It's interesting when we have discussions across the country from different types of agencies who will spend hundreds of thousands, if not millions of dollars to attain an ISO rating of X. But yet when the EMS provider wants to get accredited in the dispatch center for pre-arrival instructions or for ambulance operations and safety and all that kind of stuff, they become critical and say, why are you spending money on accreditation? Well, why are you spending money on an ISO rating? You know, maybe it does impact insurance, but you know, most of the insurance industry professionals said, you know, we banned ISO premium ratings anyway, so a 1 and a 3 might not be that much different. So it's fun fodder to have that discussion. All right, man, to help me out of this hole, do we have another question?
We have a lot of additional questions, and they're all great. Joseph Zalkin would like to know, what are agencies doing to address workplace violence, reporting, training, judicial issues, the whole boat?
JP, since he's your neighbor, do you want to answer the question for?
Yeah, and I appreciate the question because it's a super important one in our industry. And it's not just important to look at that from the field provider perspective, where maybe there's violence against our providers by a patient or a bystander, but we need to also look at that within our own organizations and as well. I can tell you that this is, I happen to be the chair of the Professional Standards Committee and the American Ambulance Association. And one of our priorities as a committee this year is looking at safety specific to workplace violence. And so we're just getting kind of kicked off and underway with that, but looking at having representatives who are experts to come in and talk to us and learn some best practices, which we'll make available to our membership. But I'll tell you, one of the things that we've done in our organization, and it might sound kind of silly, but honestly, it's, I don't know, give it a chance maybe. Put a sign. We put a sign up in the back of our ambulances that in big letters says that assault on a paramedic or EMT is a felony in the state of North Carolina. And when you're sitting there as a patient and you look at that sign, I don't know if it will make you think twice about it or not. It may be or may not. We don't have any data yet to support that it's actually done any kind of reduction, but it's something of at least a reminder. That's something we've done here. AAA is looking at, you know, some options of maybe something that could be sent out to its membership to do something similar to that. I don't have any off the top of my head other real solid options right now, but know that it is a work in progress and would be happy to report more what I find on later. I don't know if Adam has anything in his organization too that he'd like to share.
Thank you, JP. You know, interestingly, when I got back from AAA, one of the main themes, right? There's always themes that we kind of talk about, and provider safety and ensuring that we are arming and equipping our team members with the skills to be able to manage what the reality is there's an increase in the type of calls in which involve violence as well as violence against clinicians. Unfortunately, in the state of Nevada, it is more severe to batter a taxi cab driver than it is for an individual clinician that's in EMS, which is extremely unfortunate. And so our efforts are going to work towards progressing the need for us to change that legislation. But in the meantime, we have had conversations with many different individuals, one of which an institution is coming to look at de-escalation training, different defensive tactics that are obviously not offensive but defensive to ensure body armor. We've had conversations with body camera manufacturers that want to get into the EMS space. And they really, I think they're potentially, that is going to be a reality. I know there are some agencies that are currently using it. What I said to them is that if it could write a valid and clinically and billable chart, you got a market.
Yeah,
Boy,
great
you know,
point on de-escalation.
Yeah, I know in our system, Chad Carr, our compliance officer, did a great job. We actually have a barcoding system or a QR coding system to report assaults on or violence, because we want to at least be able to categorize it. And our operations team during our new employee training actually does that class for de-escalation, and it's something that we really need to try and keep up. So great comments. Amanda, another question from the group.
Yes, Mike would like to know, do we have any context for why there's such a large contrast between single focus EMS and fire-based EMS? I think he's referring to the cost slides, from my understanding, based on the timestamp.
Yeah, so let's, it's funny, Mike, that you would ask that. We provided this information to Regina's committee, the federal committee that's looking at cost of service delivery. And that was actually the very first question that came from, I believe, Regina, it was from the CMS representative on the committee.
It did.
And the short answer is, I don't know what the difference is. You'll have to talk to the fire service. These are cost reports that are done in many cases, in this particular case, by PCG. They do an awesome job. They do our cost report. They do the cost reports. Really, this is all their data. So they've done a great job in documenting costs. I can't really opine on why it's more or less in one type of provider group. Our systems, high performance, high value systems, flexible deployment as opposed to static deployment. We use type 1 ambulances that don't have an International Harvester brand on them for the ambulance. I'm not sure what many of you may know is that I think it was in August, CMS, Center for Medicaid, sent a note to the state Medicaid directors saying, we're noticing a pretty significant difference in the cost by provider type. And let us remind you that the only allowable costs to be included in cost reports are the costs of putting an ambulance in front of the address. Cost of first response is not allowed. Cost of the full station is not allowed. Cost for the ambulance part of the station is allowed. And Regina, I think CMS has actually gone to the next level. And there are states that have applied for state plan amendments to do GEMT programs based on cost reporting, and CMS is not approving them.
No,
and they're not approving them. Yeah, and they're not approving them, stating that we need to get a handle on what we're doing already, because we're not really sure that this is right. And we may be reimbursing for things that we shouldn't be. So they may want to do some additional study. They may want to do some additional reviews to see, have they been paying these appropriately or not? Regina, you have some additional thoughts?
Yes, we have solicited subject matter experts to come to the subcommittee meetings and to the actual GAPB committee to talk about the differences on the fire side versus the EMS side, so we can do a comparison. So we'll have several at the August meeting, and then we'll have some come in September. So we're trying to get our arms around that too, but it's pretty difficult to understand, and we need to look at both sides so we have a better understanding of fire versus EMS.
Thank you.
Thank you.
Amanda, one or two more questions, if there are any that are pressing or good. You just be decided if they're good questions.
Absolutely. Tina Marie would like to know, what is the solution to offset the patient service costs that are higher than the reimbursement costs?
JP?
Yeah, so I think this is a key point for us as an industry, and it comes down to reimbursement. And so you've heard a lot of discussion over the last few minutes or so about how our federal reimbursement and our state Medicaid reimbursement don't cover the cost of an ambulance service. And we've got to work to correct that. I know that the AAA, American Ambulance Association, amongst others, are working hard on behalf of our industry to try to improve that. You know, if you were to ask me what's the top two problems or top two things we have going on in our industry right now, it's reimbursement and staffing. And so that's where we're at. We've got to keep working on that, showing our value, showing our worth, and proving what our cost reporting and our expenses actually are. And I echo what Matt said earlier. If you are up and due for cost reporting, please make sure you do and do as best a job to be accurate as you can, because it is critical for us as we move forward in making sure that we can get the reimbursement that we need. And Matt, I think both Regina and Adam had their hands up there. So
Yeah, I'm looking at that on the screen. So we'll let ladies go first. Regina?
Okay. Yes, I can't speak to the unit. The JP was addressing that, but I did want to mention for agencies out there, how can you look at adjusting or maximizing your revenue cost and reimbursement cost? I think it would be very helpful, and it would affect the bottom line if people would look at understanding EMS billing codes. I think the other thing is use of technology and billing accuracy and efficiency, and understanding local and state billing regulations. It's huge. You've got to understand your locality and what the requirements are. Submit your claims accurately and on time, and then consider outsourcing your billing. I think, and I'm not saying that because I'm related or with an agency that does revenue cycle billing, but I think things are so expanded and broad now where you used to could do in-house billing. It would be helpful to understand at the federal level regulations and keep up with those regulations. So I think that can maximize the whole reimbursement side of it.
Great points, Regina. Adam?
I would agree with both of my colleagues. Obviously, very important with the reimbursement side. But the other thing that we have to pivot away from, and I hear this having many conversations across the country, is we've got to just build more infrastructure, and and that is expensive. And so we have to rethink and reimagine the 911 call. It costs me $600 to send an ambulance to a call, and having a dispatcher and a nurse process a call and paying for somebody through Uber Health or some ride share may cost me, $180 to manage that patient. So how can we manage patients and navigate them to where they need without always having to send the most expensive resource? Police department has done this very well. They don't send the SWAT team to every call because they're not needed. But when the SWAT team is needed, I'm hopeful they're available to go to those calls. Community policing, another way to reduce crime. So we've got to reimagine the way outside of the ambulance. This is healthcare, not just a ride.
totally agree with you, Adam. Great point.
This is an opportunity, and this is a WASHCO thing, but crisis breeds innovation and makes the previously unfathomable practical. And the reason that many communities are changing and I would argue right sizing their EMS system predicated on staffing shortages. And JP's right, it's staffing and funding. And I would tell you they're linked, right? Because if you don't have enough funding, you can't afford to pay people what they're worth and they don't come to work for you. And it kind of creates this vicious cycle. But really giving the opportunity to do what, like Colorado Springs Fire just won the Congressional Fire Services Institute Award for Innovation, because they said, you know what? Not every 911 call needs an ambulance response or a fire truck response. We're going to send a community paramedic to the low acuity calls. And if the community paramedic thinks we need a bus, then they'll ask for it. And by the way, we're going to tell the caller that the community paramedic will come to their call as soon as they become available from the call they're currently on. I mean, 5 years ago, would you all agree that would have been heresy, right? But today it's reality. And you know what? It's okay. Nobody's having horrible patient outcomes because we're doing what emergency departments and hospitals have done forever. Patients with high acuity medical complaints get seen right away. Those that don't have high acuity medical complaints go to the waiting room. 27% of the patients that we bring to our public hospital, we bring directly to the waiting room with IVs. I had a patient recently, or one of our crews did, 13-year-old, dehydrated, heat exhaustion, with a bag of saline and ice packs on her groin, brought to the waiting room, sat in a chair with an IV pole because they didn't need a bed in the ER, and they got dispositioned by a provider in the waiting room because they have a provider and triage system. This is the reality, and it's okay. Other thoughts? Amanda, one more question, and then we'll do thanks.
Could we do two, Matt, pretty please?
I'm sorry?
Could we do two, Matt, pretty please?
I missed the first part.
Could we do two? She
Could
said.
we do two,
Oh,
please?
okay. Yes, go ahead. Two. Yes.
Pretty please, with a cherry on top. Chief Baxter would like to know what percentage of AIMHI members outsource billing?
We have that information. Let's go to the next question, and I will look that information up now because we have it in this report.
Wonderful. And then the other question was, do you have data on the clinical outcomes in addition to the response, performance, and billing metrics? There's no question mark. There's no deviation in cardiac arrest survival, door to balloon for STEMI, trauma activation, stroke, etc.
JP?
Yeah, so actually, if I understand this question correctly, they're asking maybe why we didn't present clinical outcomes and response. We have all of this information. And I think just for the sake of this presentation, not speaking for Matt, but it was not part of this particular presentation. So we could share that right now.
Absolutely. And if they go to the website, they can download, I believe it was second or third quarter, where all the clinical metrics are. And it's all there. Utstein, cardiac arrest survival, all sorts of different things. So yes, it is all there.
And it's a good question because that is the crux of what we do, right? Why we do what we do. So that data is important and available. And just to reassure, it is being tracked.
All right, and I'm totaling up these numbers for Bruce. Bruce, it looks like about 50% of the people who responded, the AIMHI members who responded to the survey, outsourced their billing. We did, and it's for the reason that Regina actually was very articulate about, where the sophistication level, the connectivity with hospitals to get face sheets, to get discrete patient information from electronic health records, some of the clinical and regulatory complexities, payer complexities. That's all they do. And it helped us a lot and was actually less expensive on a cost per call billed. So.
Yeah, I would say it's something to evaluate by agency. Each agency has different needs, different levels of abilities and so on. Our agency at Medic, we do our own billing, have our own revenue cycle department. and have had since the inception of the agency back in 1997, as far as I understand. And so it varies. There may be benefits or pros or cons, right, to either. It's something you have to evaluate for your own service.
Great point. Regina, last comment before we do thank yous.
Absolutely. And there's a combination. When I say outsourcing, it'd be helpful for some of the federal guidelines that are being put into place, but I think you can do a combination where you don't totally outsource. So we look at doing partial outsourcing, keeping some of your local staff too, because that's another layer of looking at quality assurance and all that. So you don't have to totally outsource, but I think as things progress in the agency and we move into more of a healthcare arena where we should be, that is helpful to look at and could be a huge cost savings. So thank you.
All right, well, let that be the last word. I want to thank everybody for attending the webinar, but most importantly, thank John or JP, Regina and Adam for the time, the preparation, and for sharing their insights. Thank you to CPSM and ICMA for making sure this information gets out to their members, because these are things that local communities should come to expect, and use some metrics to measure how well their system is performing. Amanda did a great job putting links into the chat, so we'll leave this open for a few minutes to make sure people can get to the links in the chat if they want the benchmarking reports, if they want other things, they want to go to the website to see some of the industry news that we post there every week. Rob Lawrence and his team do a great job of cataloging all of the EMS related news stories from around the country. And so you've got some good information that you can share with your local community as well. Amanda, is there anything else that we forgot to mention that, as the shepherder of this herd, you'd like to share?
Just please make sure that when you visit the AIMHI website, you subscribe to our email list so that you'll be kept aware of any additional upcoming webinars, because we do try to have these approximately quarterly, and we'd love to have you back.
Awesome. All right, with that, we're going to close it out. You were giving people about 4 minutes back into their schedule that no one knows that you're available because the webinar is over. We won't tell anybody if you don't want us to. Stay safe, stay cool for those of you that are having hot weather issues in your community, and thank you for attending.